Hello, we are the alternate models to address quality of care for children with autism group.
Hi, I'm Elizabeth. I currently live in Georgia. I work as a registered behavior technician at an ABA clinic. I currently work with children who are 18 months to 12 years old as an RBT.
Hi, I'm Autumn McGee. I live in Indiana, and I am also currently an RBT working in an in-home service for ABA for children of 18 months to 20 years old.
Hi, I'm Rachel Stossel. I live in Charlotte, North Carolina, working as a RBT, providing in-home services for children ages 2 through 18.
Hi, I'm Jack Oliver. I live in Connecticut. I work at an autism center that focuses on kids like 6 and under.
Hi, I'm Megan Reed. I'm also in Charlotte, North Carolina, and I work at an ABA facility that does in-home for kids 3 to 18.
The objectives of our debate are to discuss 2 treatment options for kids with autism. The first one being applied behavior analysis, or ABA, and we'll discuss the pros and cons for the treatment, and then the medical approach to treating autism, both pros and cons. We want to compare and debate both the ethicalness of each approach and then the treatment effectiveness. Our debate is following a traditional formal debate, which will include an introduction of the topics, research in ABA, and then a medical counter, outside questions, ABA attack on counter arguments, medical attack on original arguments, ABA savage conclusion, and a medical savage conclusion.
All right, so first we will start with the history of ABA. The field of ABA was founded in the 1960s out of a traditional psychology field of behaviorism, where the focus of ABA is on changing socially significant observable behavior. Early applications of ABA focus on punishment procedures, and many methods are considered unethical today. ABA tends to get a lot of backlash due to old views, but it is important that people realize that these unethical interventions are no longer practiced in the field. And another important note is that there are now strict professional and ethical codes of conduct that are in place and strictly followed by the professionals practicing in the field. And this would be found under the Behavior Analyst Certification Board. To introduce ABA, it is one of the most well-researched and database intervention strategies for people with behavioral problems, often correlating with autism spectrum disorder, or ASD. More than 20 studies have established that intensive and long-term therapy using ABA principles improves outcomes for many, but not all children with autism. And intensive and long-term refer to programs that provide 25 to 40 hours a week of therapy for up to 1 to 3 years of service. And these studies show gains in intellectual functioning, language development, daily living skills, and social functioning. Moving on to the foundation of ABA, it is a research-based where data can prove the benefits and success rates to be most successful intervention strategies in all aspects of a child life with ASD. Behavior analysts are also able to look at data and research to determine what could be effective to then replicate it to benefit others. One key component of ABA is that the science behind ABA allows for the ability to predict within a certain degree of competence, which is valuable and useful result of science, and prediction enables preparation. The key words here when thinking about a science-based intervention would be prediction and preparation. Data allows professionals to be able to predict or hypothesize different outcomes as well as prepare us for uncertainties that may arise. Moving forward, ABA strategies are used to help all aspects of one's life, whether that be social goals, behavioral goals, safety goals, community goals, academic goals, communication goals, self-care goals, or academic goals. Since ABA has extensive research that continues to grow, there are strategies that can be used to create a better life for people with autism or other disabilities. Now we look at a chart which represents the research performed in different areas of practice in the field of ABA by professionals in the field. This shows the extent of research performed in only 1 year, as well as the variety of different areas and specialties in the field. This graph shows the effectiveness of ABA intervention strategies and how the strategy had a decrease of problem behavior. Research on autism has been the main focus and the majority of research in the field, with 67.65% of research related to autism specifically. However, this allows you to see all the other categories where research has been conducted that ABA could also benefit in these areas, including population of child delinquency or brain injuries, as well as enhancement of the family's lives through parent training. This next graph displays the effectiveness of ABA intervention strategy to reduce problem behaviors. This graph shows the effectiveness of ABA intervention strategies and how the strategy had a decrease of problem behavior. This graph is a published research article that other analysts in the field could use to replicate for other persons with problem behaviors. You can see that at the beginning of the sessions, when there was no interventions in place yet, there were at the most 12 occurrences of problem behaviors that were happening per minute. And then by the end of the intervention, the problem behavior was consistently occurring 0 times per minute, even across different settings as well as different staff members. The graph is a representation of how effective ABA strategies could be for a person that has intense or frequent problem behaviors that are negatively affecting their everyday lifestyle and well-being. This next graph is a personal graph that was done by me as well as my supervising BCBA in the field. And this graph depicts the accumulated skills acquired in only 15 months from a child that has been diagnosed with ASD and receives full-time ABA services. This graph depicts that the client has accumulated over 600 new skills within only 15 months of receiving ABA services. All skills that have been acquired by using a combination of ABA strategies, techniques, and interventions in the areas of social skills, communication, language development, cognitive skills, life skills, academic skills, and functional living with self-care skills. And these were all to increase the quality of life for this child with ASD. This graph truly shows how effective ABA strategies can be and how many new skills can be achieved in a short amount of time, all due to ABA strategies that will now all have a positive impact on one's life and all aspects of his life.
While there is no medical proof for autism, the use of medication has been used for years to treat autism and symptoms of autism. The medical model utilizes the use of medications, including antipsychotic medicines and contemporary and alternative medicines, to minimize the symptoms of ASD. When symptoms are diminished, they are no longer seen as problems and therefore allow the person with autism to focus on other things such as learning and communication. Antipsychotic medicine, which is also sometimes referred to as tranquilizers, is used to treat behavioral symptoms such as irritability, aggression, self-injurious behaviors, and hyperactivity. It can also be used to treat motor tics and mania. Contemporary and alternative medicine may help to decrease behavioral symptoms as well as other autism-related symptoms in the forms of special diets, such as gluten and casein-free, vitamin and dietary supplements, remedies, and hyperbaric oxygen. Medical treatment has been shown to be effective in helping treat related comorbid conditions that many children with autism often experience. A few of these are including anxiety, depression, gastrointestinal problems, OCD, ADHD, and these are just a few to name some of them. This table shows features of the medical model of autism. In the figure, you can see possible etiologies, possible pathologic processes, the clinical syndrome of autism, and possible treatments that are represented. 3 of the 4 possible treatments, which are symptomatic control with psychotropics, specific neuropharmacologic treatment, and prevention via genetic counseling or amniocentesis, and therapeutic abortion, are 3 different medical treatments listed as possible treatments for autism. So out of the 4 possible treatments that are noted and listed as treatments for the medical model of autism are all of medication based foundation. So the use of certain medications aim to curb a range of problematic and sometimes dangerous behavior patterns that people with autism often experience. The use of this form of treatment typically makes these children less of a threat to themselves and to others. And as you know, we're all about safety, safety of yourself, safety of others, and that should always come first and foremost. Prescribed and monitored, certain medications can decrease the appearance and occurrences of the symptoms of autism. And chronic management of autism is important because, as a child progresses and grows up, some symptoms will occur more rapidly, more thoroughly, and more severely. Medical care can have a positive impact on the quality of life for those with autism and those that they surround themselves with. The next table features the core deficits of associated behaviors of autism, which all may be currently treated in some form or fashion by medicine. So just to go through this table really quick, so some of the core deficits listed are impaired social interaction, which includes preferring to play alone, lack of peer relationships, rare initiation of interaction with others, missed social cues, difficulty with social engagement or social withdrawal, lack of interest in sharing pleasure or gratification with others, lack of nonverbal communication to monitor or control social interactions, difficulty with empathy, lethargy with no drive for social interaction. And some of these associated behaviors of these core deficits include hyperactivity, inattention, impulsiveness, and restlessness. So some of the core deficits that are included with impaired communication and imaginative play include difficulty with communication engagement, difficulty reading body language, speaking with fixation on a topic, echolalia, delayed or deviant language, muteness, reversal of pronouns, difficulty with creative thinking, and difficulty with reflective thinking. And some of the associated behaviors that pair with these core deficits include tantrums, self-injury, anxiety, irritability, maladaptive behavior, emotional liability, and aggression. And then at the bottom of the chart, The last core deficits that are listed are restrictive repetitive activities and interests, which are labeled as bound by routines, intense focus on favored objects, and associated behaviors that are matched are obsessive compulsive like behaviors, motor stereotypies, hand flapping, rocking, lip licking, sleep disorders, which include difficulty falling asleep and difficulty remaining asleep, and motor tics. So here is just a few of the medications used to treat some of these core deficits and behavior associated behaviors. For OCD, rigidity, depression, and self-injurious behavior, they are usually treated with antipsychotics, antidepressants, selective serotonin reuptake inhibitors, also known as SSRI, anti-anxiety, sleep medication, mood stabilizers, and stimulants. Antidepressants and SSRIs increase the levels of serotonin in the brain. Possible side effects include decreased appetite, hyperactivity, agitation, and insomnia. Hyperactivity, ADHD, restlessness, and impulsivity may be treated with stimulants, which increase the levels of dopamine in the brain. Possible side effects of this include irritability, loss of appetite, moodiness, tics, and hallucinations. Stress, irritability, agitation, and anxiety experienced by those with autism may be treated with anti-anxiety medications. In this case, possible side effects include heart rate problems, sedation, nausea, and vomiting. And then those with autism who experience seizures, bipolar mania, self-injurious behavior, hyperactivity, aggression, or mood swings may be treated with mood stabilizers and anticonvulsants that are used to decrease the frequency of these symptoms. And possible side effects of these include hyperthyroidism, sedation, liver, and kidney problems. But even though there are a lot of side effects, pediatricians, doctors, and prescribers support, the use of medications because they do help manage the comorbid conditions that individuals with autism experience. Pediatricians, doctors, and prescribers provide support by providing routine preventive care for individuals with autism. They help to manage the symptoms and outbreaks of the comorbid conditions that individuals experience. They help with associated medical problems and coexisting conditions, and they help to maximize the child's ultimate functional independence and quality of life. The main benefits and goals of the medical model are basically to just minimize the core autism features. They help promote early diagnosis and early intervention, which helps an individual to progress through life as best as they can. They facilitate development and learning of individuals. They reduce maladaptive behaviors and symptoms. They promote socialization. And they also educate and support the families of those with autism. But they also, one of the benefits and goals is also to raise awareness of autism. And by doing this, it also helps to just, educate everyone else around them about what's going on in these individuals' life to just spread awareness to hopefully benefit everyone with autism as the ultimate end goal. The final table representing the medical model is the top 10 treatments for autism, ranked by percentage of respondents reporting use. In this table, as you can see, medications are used by 40% of individuals in the U.S. and 49% of individuals with autism nationally. The graph also depicts the percentage of individuals utilizing ABA, in which 29% in the U.S. and 30% of those with autism nationally responded as useful in intervention. So as you can see, medications in this table is preferred over ABA, as well as a few other of the listed therapies. And people are finding medications useful and are using them in the treatment of autism.
Currently, for the medical model, this is the attack on the medical model, there's limited research which is focusing mainly on causation of why individuals have autism. So the focus on causation does not currently do anything to help improve the quality of life for individuals who have autism, but is more a preventative action for people who may develop autism in the future. Understanding what causes autism can lead us to a better understanding of why different characteristics are present and how to better help build skills. But currently, there's no definite answer on the causes of autism, and the medical model does not have any current treatment options that are focused on teaching skills to individuals or how to use adaptations to be successful where the individual is currently at. This relates directly to Ethics Code 2.09 from the BACB, which is treatment efficacy. So clients have the right to effective treatment with both long-term and short-term benefits. Medical model focuses on treatment intervention at the moment, but doesn't necessarily have research to back up its effectiveness over time. So it's mainly looking at problem behaviors and how to treat those as well as comorbid conditions. And then according to an article by Ritvo and Freeman on the use of medical model with individuals with autism, the number one possible treatment listed is structures behaviorally based individual education, which is the basis of applied behavior analysis. So in a medical research study, their number one solution was a different field of study. Although they mentioned different medications and different uses as well, it was important to note that that was their first listed treatment. In the article, A Medical Model of Autism, Etiology, Pathology, and Treatment by Ritvo and Freeman, one of the suggestions for future treatment is looking to identify potential genetic markers in individuals with autism to identify in a fetus if that child will have autism in the future and be born with autism. Currently, that's not possible, but if the science can identify these markers in the future, the suggested treatment option is a therapeutic abortion to terminate the pregnancy and terminate the chances of more individuals with autism being born to solve the problem of what to do with autism. This is a very sensitive topic and leads into the discussion on neurodiversity and whether or not eliminating autism from the population is a positive or negative decision. Looking just at the ethics of it as if the individual were a client, it would apply to Ethics Code 2.0, which is behavior analyst's responsibility to clients. Due to the fact that a therapeutic abortion would not provide treatment because the client would no longer exist, this causes an issue as a field for applied behavior analysis. And because autism is a spectrum or a continuum, there's no way of knowing what level of severity or impact that child may have because of their autism. So if the child is aborted, you don't know if they're going to be higher functioning or be more severely impacted. There's no way of knowing. So they don't have a chance to improve functioning because you would never find out where they were at on the spectrum. Another code that's applied is Code 2.02, the responsibility to all parties affected by services, helping to provide families with accurate information about the options available becomes vital at this point. If you're not talked about what options are there for you for your child, you may think that your only option is therapeutic abortion and that your child is going to be severely impacted and won't be able to do all these skills. But if you're not given the information on the reverse side, you can't make a educated decision. And the final code that was affected is 2.05, the rights and prerogatives of clients. In the field, we'd have to focus on the right of the client in this situation, and that would mainly be advocacy and education about where that child could be in the future and what skills or functioning is available to them based on what we already know about autism and the range of individuals and differences that we can currently see. All of the previous codes and information so far on issues with the medical model have focused on a lack of autonomy for individuals with ASD. Bailey and Birch point out that this view of the medical model in general is that the individual is sick or there's something wrong with them and they need to be fixed or cured. By looking at clients in this way, they lose their voice and a chance to work with where they are at and the skills that they have, or working to develop new skills instead, and are being told that they need to change and be a different kind of person in order to be viewed as acceptable by society. And medication is the main treatment focus for individuals with ASD in the medical model. There's currently a lack of research on the effects of different medications in the medical model. One common medication used is the antipsychotic medications. This is frequently used to treat irritability behaviors like aggression or self-injury, and can also be used with hyperactivity and stereotypy behaviors. The psychotropic drugs are typically used in 65% of clients in youth with ASD, which is a very high number. And they're on at least one, so there could be multiple medications that they're also taking. And a problem with that is the research doesn't state that it's successful for most individuals. It's kind of got mixed reviews on whether it's working or it's not working. And the side effects that come with taking those medications can include weight gain and obesity or other issues that are already at risk for individuals with autism. So if you're already at risk of being overweight and having obesity, and then you take a medication that's going to increase those chances, it can put you at more harm than success when you're on the medication. In another study by Wink et al., they looked at the side effects of medications for individuals with ASD across the treatment group, and they found that some of the side effects that they saw in these kids were weight gain, sedation and tiredness, increased tics, drooling, self-injury, speech problems, repetitive tongue and mouth movements. Like I had said previously, a lot of these side effects are already issues that kids with autism are dealing with. So if you have increased weight gain, increased speech problems, and repetitive movements, when that's already a characteristic of the diagnosis, you're limiting your functioning even further than it might have already been at. So you have to then make that choice if it's going to help your kid or if the medication will set them back even further and increase new issues that you have to then target, as well as the current ones that are already happening. Another question was, are they going to make will it outweigh the behaviors that they're changing? So your child may no longer have, they may no longer have this one behavior, but now they're not eating, or now they're not able to communicate effectively and are slurring their speech when they already had a very limited speech repertoire. Another type of common medication that's used with kids with autism is anti-epileptic drugs. It's kind of its own little area in autism research, that autism and epilepsy can coexist frequently, and having seizures a lot is an issue that a lot of parents were looking for medication help from. However, in a meta-analysis by Hirota et al. In 2014, they looked across seven different studies looking at anti-epileptic drugs, and they found that between the two groups, there wasn't a large enough effect that it was helpful to be a like proven treatment to say, okay, this is successful and this will work with all of your clients. The effects were too inconsistent across all of these different studies to show that there is a high rate of success with this type of medication. So then you have to outweigh your risks again as a parent or an individual choosing to put yourself on this medication. Another topic that comes up when you look at the medical model and medication with individuals with autism is that they're more violent, so that they need to be on medication to decrease violent tendencies. A lot of this leads to aggression outbursts in society, and if they're a risk to others because they might hurt somebody or kill somebody or do these different types of illegal behaviors. However, a lot of the research that's conducted on individuals with autism committing violent acts is very skewed. They're taking the data on only looking for individuals with autism. So how many people committed this crime that have autism? Let's go find all of these people, versus just pooling the general, like all of the cases. And then, so it looks like the percentage is higher because you're only looking at one subgroup type of people versus the percentage of individuals with autism who are committing the crimes compared to the general public. At that point, the levels are very low and are less than or about average with the general person. So they're not more of a risk for others to commit these types of acts, which can be misleading in the current research for media that is out there.
So for the attack on ABA, I first wanted to discuss Lovaas, who is considered a pioneer in the field of ABA. He first started as an assistant professor at UCLA in 1961, where he had means of attending UCLA to study psychoanalysis. But then he was intrigued by the work of Sidney Bijou, who was using the Skinner approach and encouraged positive behaviors. The consequences that Lovaas thought that verbal praise was useless for a nonverbal child. So instead, he used adversives with an experiment on Beth, who engaged in self-injurious behaviors. And this was the 1966 study. The use of physical adversives include beatings, electric shocks, and withholding of food. Kirkland 2017 stated that the use of physical adversives was better than being held in an institution, and that was stated by Lovaas. So some limitations of ABA, although it was founded in 1945 on Skinner's radical behaviorism, it's still a relatively new science. In the 1960s, Ovar Lovaas published his research on applied behavior analysis therapy, and his research wasn't taken seriously by medical practitioners until the results for his study that was published in 1987. The study in 1987 involved two groups of children. There were 19 children in one group who were in 40 hours of behavioral treatment weekly for 2 years, and the control group, which contained 40 children, received 10 hours or less. The results of this study stated that 47% of students were found to be normally functioning after the 2 years of treatment. But many have tried to replicate this study and have failed. The evidence for ABA as a contribution to behavioral medicine is very limited. Behavioral medicine is the best way for behavior analysts to contribute to the field of medicine. The only information that's listed in the Encyclopedia of Behavioral Medicine is information regarding behavior change, behavior techniques, and behavior behavior change related to operant conditioning, stated by Greenwald, Roos, and Williams in 2015. And that accounts for only 10 pages compared to the 2,000 pages covering medical information. ABA focuses on disorders related to autism, which can include social, communication, self-care, and academic skills. There isn't specific treatment in ABA to combat other comorbid disorders that individuals may have along with their autism. So some client thoughts on ABA from Shribman in 2005. Some ABA procedures can be overly mechanical. Parents state that ABA is harmful due to the therapy trying to make them normal, as stated by DeVita and Rayburn in 2016. Some examples were parents were saying that discrete trial training procedures have been stated as being robotic and prompt dependent. The example by DeVita and Rayburn states that kids will be taught to ask someone, hello, what's your name, but will not wait around for the answer from the other person. And instead, they'll walk away because they're only taught, basic communication skills, such as asking someone what's their name, but are unable to wait for the other person to respond. Parents are also taught to keep the same routine, to create a low stimulus environment, and it becomes overwhelming to the family structure. Clients preferred treatments that would help them understand their disability more instead of making them look less autistic on the outside. And this quote from Gardner in 2017, the therapeutic goal was presented as learning social behavior. In retrospect, this was learning to mimic neurotypical or non-autistic social behavior. It resulted in corrosive damage to self-esteem and deep shame about who I really am. No effort was made to explain autism to me or explain the role of sensory overload in issues like meltdowns, shutdowns, and etc.
ABA has proven to have extensive research allowing professionals to be able to replicate interventions for others to benefit from in different areas of their lives. As well as the field of ABA also has strict ethical guidelines that are followed by professionals in the field to ensure that ethical interventions are being implemented, as well as ethical interactions between professionals and clients and their families. As well as another key point is that an ABA program is individualized to not only the client, but also to the family's needs. And a professional will individualize these goals in all deficit areas of one's life. So the ABA offers not only support for the client, but there's also research that has been conducted to help train parents so that they are included on the journey, as well as and they can fully understand how to help and support their child throughout the intervention process.
The medical model has been found to and used for managing and controlling symptoms of autism. While there is no cure for autism out there currently, there are medications and strategies that are out there to help individuals with autism manage and control what they're experiencing, what they're going through, and learn and help them to learn to navigate the symptoms that they experience. The medical model promotes early diagnosis and early intervention to help the individuals with autism go ahead and get a head start on managing and controlling their symptoms and learning to function in society and as an individual. The medical model facilitates development and learning of individuals with ASD. It educates and supports families of children with ASD, and it also raises awareness of autism all around. So the medical model not only pertains to the individual with autism, but it also promotes engagement and positivity for the families and helps them to engage and make connections in society.
So for the questions to our debate, how would you explain your ethical responsibility to a parent who wants you to implement an alternative strategy? I would start off by explaining that with ABA and any treatment, it should be evidence-based. There should be a lot of research behind it saying that this is possibly an effective treatment that will help your child and do minimum to no harm at all. And then to add to that, those alternative treatments should target socially significant behaviors, meaning they should target behaviors that will help the individual grow and develop and become independent, and that are important to you as a parent and to the society that you guys live in.
To add on to the first question, Ethical Code 2.09 states that clients have a right to effective treatment. Part A states that they have a right to evidence-based treatments, and Part D also states that behavior analysts will evaluate any treatments that may affect the behavior change program goals.
I think it's important to note that you also have to be able to be trained in the treatment. So if they want you to implement something that's like out of your scope of practice, you have to explain that to them as well, that we're only covered in so many areas. We only can teach your child or work with your child on things we know how to actually implement.
To go to question 2, what are some strategies behavior analysis can use to effectively corroborate with professionals from other fields who utilize alternative treatments to kind of foster communication between all treatment, all individuals working with a client? It's actually an ethical code 2.04, third-party involvement in services. So it's the responsibility of the BCBA to go out of their way to make sure that every individual involved with the client has access to the necessary documentation to effectively implement the procedure. And then in the modern age, what is used a lot in my company is Google Docs. We have Google Docs open with OT and speech therapy, where they have access to behavior plans and ongoing notes of any problems that may arise during a session. And then to go to question 3, do you have any personal experiences related to this topic that you'd like to share? Since all the members of our group are relatively new to the field, none of us have any strong ethical situations that we could share at this time.
I do slightly, working with a case where medical issues are a high priority for the client. You really have to be on covering all your bases with all of the different doctors or service providers you work with, because when there's different medical issues going on, it's really hard to tell as a behavior tech working with the client what's behaviors and what's medical side effects. So you have to know the medications your clients are on, the dosages they're getting, if a dosage was skipped or information like that, to be able to do the 2 treatments interchange or at the same time. Because if you don't have all the information, you may be able to help treat some instances of the behaviors with medication, but you can't target other skills just with medication. So you can use ABA therapy to do that. But if you aren't on medication or your medication's not stable, ABA therapy can't always be effective because you don't know what's causing the behaviors, if it's really a behavior issue or if it's something that's being medically induced.
I also wanted to include that it's important to make sure that you are aware of if there's a medication change with your client for graph purposes, in case there's an increase in aggression or just an increase in a frequency of behaviors that are in the behavior change program, to mark it down in your notes, and also for when your graphing data to include like a phase change line to show that, hey, this is what increased when this medication was implemented, or this is what decreased when this medication started.
And that concludes our debate.
Thank you.